now. So yeah, sure.
All right. So I just first wanted to say welcome to all of the applicants, because we had a great group of applicants coming through today to virtually visit the University of Washington Neurology program. And I think you will witness a fine example of the residency program here tonight, because Dr. Amy Steinberg is one of our fabulous residents and obviously one of our chief residents as well. And taking a feather from Dr. Coates' cap, if we go back in time to grade school, Amy apparently attended multiple elementary schools, but she said Colorado Academy in Littleton, Colorado was where she spent most of her time. And then if we fast forward, she went to Stanford for undergraduate, where she was English and creative writing major. And then she spent a year doing Teach for America in San Francisco, teaching science to 7th graders, which is a lofty thing to do. And then she went off to medical school at UCSF. And we were lucky to attract her here to the UW, where she really has been a pretty phenomenal resident, who's really known for her clinical acumen and her excellent communication skills. And so I am thrilled to introduce her and to hear her presentation.
Great. Okay, thank you so much, Dr. Davis. So I'm going to be talking about a case of vaccine-induced thrombosis with thrombocytopenia that resulted in cerebral venous sinus thrombosis. And I have the honor of being joined by experts in hematology with Dr. Garcia, neural palliative care with Dr. Kreutzfeld, and epidemiology with Dr. Lynch. I have no disclosures. I do want to say, you know, this is not an M&M conference. That being said, oops, let me just, that being said, this case has had, you know, some attention, and so it goes without saying that anything discussed here stays within the confines of this conference and is non-discoverable. So before we get going here, I want to acknowledge that this is a really difficult case in which a person has died from a public health recommendation, in this case, the vaccine. And I've been thinking a lot about why this is such a difficult case. You know, after all, we see any number of young, previously healthy patients suffer neurologic devastation with, unfortunately, some degree of regularity. So for me personally, when I have these types of issues, I turn to some of my favorite writers, which in turn, as evidenced by all the people pictured here, led me down quite a rabbit hole, and I will spare you, but I did keep running across references to the idea embodied in this quotation, which I think captures the moral complexity here. And it says, "Nothing in the world, indeed nothing even beyond the world, can possibly be conceived which could be called good without qualification, except a good will." And I do actually also want to take a minute to share a couple of the reasons why I do think that this case is different in its difficulty. So, you know, firstly, this is an entity, the entity we're going to be talking about today is brand new. And with that comes a degree of powerlessness and unfamiliarity with the odds. We don't know what we're willing to tolerate with respect to outcomes because we don't know what to expect. You know, in contrast, we all know that a plane crash is a possible outcome of flying. It's horrible. We have procedures and protocols to avoid it, but it's a, quote, accepted risk. And secondly, bad outcomes that are the result of a choice are always followed by a desperate attempt to, you know, attribute blame and a replaying of what if, I think much more so than, say, a diagnosis of cancer, for example. Both are equally as irrational, but I think a different emotional response. And thirdly, obviously, there's been no shortage of pain and suffering during this pandemic. And to add to that, a case wherein one of the beacons throughout all of this, i.e. vaccines, causes significant harm, feels in some respects like the straw that breaks. And then finally, you know, this is a scenario where the benefit of the public came at the expense of an individual's life. And two contrasting ethical frameworks that I do want to briefly introduce. So obviously, this all comes with the caveat that, you know, 1,000 people died from COVID, the disease, yesterday. So, you know, the context and perspective is obviously valuable. And understanding these two ethical frameworks was helpful for me in articulating some of the tension in this case. And so I do want to share it with you. So on the left, let me see here, we have utilitarianism, and this is an ethical paradigm in which goodness or badness is determined by the results or the outcomes. So the outcomes always determine the means, and decision-making is based on what will benefit the majority. And this is really an impersonal moral dilemma embodied by the trolley car problem, i.e. your action to pull the lever will save 5 people. And so the person killed wasn't necessarily done by your own hands. And this is really in contrast to deontology, which is an ethical paradigm in which goodness or badness is determined by the action, and thus adherence to duties and obligations are of the highest importance. And so here it's the motive that matters, and the ends may not justify the means. And so decision is making is based on principles inherent in the action. And this is more of a personal moral dilemma embodied in the footbridge problem. And so you're standing on a footbridge, and this is going over the same train tracks. You can push someone off, hit the carriage and stop the trolley, thus saving the same 5 people. And the outcomes are the same between the 2 problems, but the ways of conceptualizing the motives are different. And I think it's important to note that public health kind of operates within the utilitarian paradigm, and we in kind of the physician-patient relationship operate a little bit more in here. And I think herein lies some of the tension that at least I felt in this case. I think this obviously does not apply perfectly to our case because the risk of disease itself far outweighs the risk of bad outcomes from vaccine, but nonetheless, I thought there were helpful paradigms. Okay, so with that, here's our agenda. So we'll go over the case. We'll have pathophysiology with Dr. Garcia of hematology, neuropalliative care with Dr. Kreutzfeld of neurology, and epidemiology with Dr. Lynch. And then we'll have some time for questions. So our patient is a 37-year-old woman who presents to the ER with low back pain, malaise, myalgias, and a frontal headache. She says, I've really been feeling off for the past 2 days. I've had some cramping and some flank pain that radiates in my stomach. I've got a frontal headache. And upon astute questioning by the ER, she says, I got the J&J vaccine 9 days ago. And thus we'll use day 0 as the day of vaccine administration. And so this is day 9. She really only has past medical history of preeclampsia with her first child. She does not take any medications, including no estrogen containing medications. She is only allergic to Neosporin. She doesn't use tobacco, drugs, no significant alcohol use. She works as a stay-at-home mom and volunteers in her kids' school, and she has no family history of bleeding or clotting disorders, no strokes, malignancy, or autoimmune disease. So in terms of initial objective data, these are her vitals, which all look great, her initial vitals, her pertinent exam findings in the ER. So she was ill appearing. She had some abdominal tenderness. There was likewise a comment of flank tenderness, though notably no focal neurologic deficits. And she had some labs. She had a CBC, which showed a thrombocytopenia to 38. We don't have any history of labs on her. She had a BMP with just a mild hypokalemia. She had a UA, which was really largely unremarkable, although the culture at this point still hadn't resulted. She had a serum pregnancy that was negative, and she had a COVID PCR that was negative. And in the ER, they got a CT of her abdomen, and the prelim read on that was circumferential bladder wall thickening, correlate to the urinalysis, as well as mild intrahepatic biliary ductal dilatation. So she got some Toradol, she got some ondansetron, she got some fluids and some hydromorphone. So she presents at about 10 p.m. and gets all that testing in the ER. And really by 7 a.m., her symptoms had greatly improved. Her and her husband both wanted to go home. They were discharged with antibiotics and quite strict return precautions with a plan for repeat labs in a couple days. Then at around 10:15 a.m., there's an overread of the preliminary CT abdomen, which calls a thrombosis at the left renal and ovarian veins, recommending a duplex or an MR venogram. She's immediately called by the ER to return, but unfortunately it was difficult to get a hold of her. Then around 3 p.m., her husband has a difficult time rousing her from a nap. She had fallen asleep at about 1 p.m. and he was unable to wake her, prompting a call to 911. So the medics arrive at 3:30 p.m. They note that she is unresponsive, and per their run sheet, she is afebrile, heart rates are in the 70s, her systolics are 160s. She's satting 99% on room air, and they say, you know, she's not following commands, but she's got motor movement in the upper extremities. Pupils are 4 millimeters and reactive. And so she gets back to the ER at about 4 p.m. And neurology is involved at this point with the stroke code. And in triage, she's noted to have a GCS of 5, some decerebrate posturing. She has an NIHSS of 35, notable for not following commands. Though her eyes are open, her right arm was held in flexion. Otherwise, she did not have any spontaneous movements. And at this point, there's concern for her airway, and so she is intubated. So this is her first, the first head CT as part of the stroke code initially, the non-con head CT. And so what you'll see is a right frontal interparenchymal hemorrhage. She has some pretty significant mass effect with compression of the lateral ventricle, as well as of the third ventricle, with about 7 millimeters of midline shift. And also what you'll notice here is there's really quite a remarkable degree of edema, which does go along with the pathophysiology of venous stroke. And I'll get to that in just a second. She was unable to have a formal venous study, though we did have a CTA, and the arterial system was completely open on the CTA. But we don't have good visualization of the venous system. And, you know, there's some suggestion of a superior sagittal sinus clot, and certainly this hemorrhage location would fit with that. But we obviously can't say for sure with the imaging studies that we have. So just a brief overview of the pathophysiology of venous stroke. So first we have a schematic of normal brain. Obviously blood is traveling through the artery to the capillary and then into the vein. We've got parenchyma here, ventricle here. And in venous stroke, we have some occlusion of the venous system, which leads to congestion, engorgement of the vasculature, and you'll get some mild pressure buildup. And then we really start to see Starling's principle at work. You have increased hydrostatic pressure with fluid moving into the interstitial space. And in venous stroke, you really have first and foremost a relatively slow increase in pressure and edema formation. And this increase in hydrostatic pressure ultimately leads to breakdown of the blood-brain barrier and resultant vasogenic edema. And the pressure in the vessel then results in either vessel rupture, or the tissue pressure exceeds the capillary pressure, capillary lumen collapse, and you have ischemia. And so this is obviously in contrast to arterial injury, in which the vascular insult is sudden and edema is the result of subsequent infarct and hemorrhage. And so in arterial injury, there's really no buildup of edema beforehand in the setting of arterial interparenchymal hemorrhage. And so this is the post-contrast image from the same study in the code stroke, which shows active extravasation into the hematoma collection with multiple foci of enhancement seen along the inferior and superior lateral margins of the hematoma. And in a nod to UW neurology, the active extravasation or quote spot sign was first described at Harborview in 1999 by Dr. Becker, and obviously colleagues that are very familiar here. And when it was found that active extravasation of radiographic contrast was an independent predictor of mortality in patients with primary interparenchymal hemorrhage. And so this picture in our patient then is overall quite concerning for active hematoma expansion, but it's also quite unusual if we are implicating venous congestion and backflow pressure as the etiology of the bleed. And recall, she had a completely open arterial system. Her blood pressure was not impressively high during this period. And it seems that this is actually quite rare, as there are only scant case reports of cerebral venous, or excuse me, of ICH secondary to CVST with a spot sign. So this is a case report from 2018, but they don't have any mechanism indicated here. So overall, I think what we can take from this, is that this is concerning for poor prognosis, although otherwise it remains somewhat a mystery. So after the code stroke, hematology is consulted and they recommend the following labs. So she gets a repeat CBC. Her platelets are now 31,000 down from 38. She has a coag panel, which is really not all that remarkable. Her INR is a little bit elevated, same with her PT. She gets hemolysis labs, a D-dimer, and what you'll notice here is her fibrinogen is really quite low. Her D-dimer is above the level of detectable by the lab. And unfortunately, the PF4 antibody or the platelet factor 4 antibody or the HIT panel couldn't be sent at this time in the ER. And so with these aforementioned labs, hematology infers at this point that based on her unremarkable medical history, the acuity of her presentation, the tempo of her symptoms and her clinical findings alongside her labs suggests a likely diagnosis of thrombosis with thrombocytopenia syndrome. And so this is the current working diagnosis for TTS by the American Society of Hematology as of August 2021. And this was what was used by the hematology team in diagnosing our patient. And so the first criteria is COVID vaccine 4 to 42 days prior to symptom onset. Secondly, any venous or arterial thrombosis. Thirdly is thrombocytopenia, although with the caveat that a patient who presents with thrombosis and a normal platelet count post-vaccination might be in an early stage of TTS, as kind of based on the model of HIT or heparin-induced thrombocytopenia. Fourth is a positive PF4 ELISA, and fifth is a markedly elevated D-dimer. It should be noted that these are more strict criteria than the prior Brighton criteria, which defined TTS as confirmed thrombosis, new onset thrombocytopenia, and no known recent exposure to heparin. The Brighton criteria did not include the PF4 antibody or the elevated D-dimer. And so at this point, she meets all of these criteria, although we don't have the PF4 HIT ELISA. And so in continuing with her clinical course, so she has the stroke code at 4 p.m. She is intubated and hematology is consulted and at this point diagnosed with TTS. And throughout the next couple hours, she receives 3.5 units of platelets. She gets 2 units of cryo. She receives hypertonic saline. She gets mannitol. She gets some levetiracetam, and she started on IVIG 1 gram per kg. And at 8 p.m., she goes to the OR with neurosurgery for decompressive hemicraniectomy, also for ICP monitor and EVD placement. And so this is the note from the neurosurgical team following the decompressive hemicraniectomy, in which they report the brain tissue was noted to be quite unusual and that it was quite dusky and appeared underperfused. In addition, bleeding from the cortex was not at all responsive to bipolar cautery and had to be stopped with hemostatic agents and local pressure. They further document spontaneous venous hemorrhages out of the cortical surface, and the pathology report states fragments of organizing and acute hemorrhage and brain parenchyma with ischemic changes. And these features described by the UW neurosurgical team have actually been described in a neurosurgical case series by Gessler et al. In 2021 in the Journal of Clinical Medicine. And they looked at 3 patients with CVST following vector-based vaccine. And they describe, intraoperatively severe bleeding and venous stasis still posed a challenge to the surgeon, requiring immaculate hemostasis despite a cautious intraoperative strategy with an effort to avoid injury to the brain. In all 3 of their cases, the use of artificial hemostyptics and further transfusions controlled intraoperative bleeding. And in these patients, the post-op imaging showed improvement of the CVST, but marked progression of intraparenchymal hemorrhage and And unfortunately, all 3 of these patients died. And so again, returning to our clinical course, so the team overnight really has difficulty with refractory ICPs to greater than 40, despite really aggressive hypertonic therapies. And around 2 a.m., she loses pupillary responses. At this point, her EVD has stopped draining, and it's felt as though she's clotted off the catheter. And so as such, she goes for removal of the right EVD and placement of a left-sided EVD. And then shortly after that, upon returning from the OR, she again has refractory ICPs. The catheter is again felt to be clotted off, and she returns to the OR for a 3rd time for revision of the left-sided EVD and replacement of the right-sided EVD, so that at this point she then has biventricular drains in place. And in the afternoon, the HIT antibody panel and SRA returned positive, and after discussions between the ICU team, neurology, neurosurgery, and hematology, she started on a bivalve drip upon returning from the OR. Unfortunately, just shortly thereafter, both EVDs again are non-functional. They're thought again to have been clotted off. And despite the team's best efforts, she continues to show signs of elevated ICP and herniation, and endocrine is consulted with concern for diabetes insipidus. And at some point between hospital day 2 and day 3, her ICPs were up near 71. She continued to herniate and she loses brainstem reflexes. And the first brain death exam is completed the afternoon of hospital day 3 by the neurology team. And the second brain death exam by the ICU team shortly thereafter, and she's pronounced at 3:57 p.m., so 12 days after vaccine administration. And this is the last head CT that she had had after it was felt that both EVDs were not reliably functioning. So really quite profound edema. She has subfalcine herniation, uncal herniation. She has herniation out of the craniosite. She has multiple compartmental hemorrhages. She has bihemispheric ischemia.
Amy, do you think that ischemia was all still venous, or due to the ICP, she started having arterial ischemic events as well?
Yeah, I think, we were talking about this in stroke conference. I think some of this was the result of subfalcine herniation, just kind of some of this ACA distribution stuff on the contralateral side. I do think, just based on what I've been reading about the pathophysiology of this process, however, that some of this is ongoing venous infarction as well. Though I don't know how you distinguish between all of them per se.
It's like a big MCA infarct on that right side as well.
Yeah. So just to recap on our timeline, so day 0, she gets the J&J vaccine. 9 days later, she presents to the ER. She has back pain, headache, malaise, and myalgias. She's feeling a lot better the next morning and is discharged home. 10 a.m., we have the CT abdomen overread. At 1 p.m., she takes a nap. And at 3:30 p.m., family calls 911. She then arrives back, and at 4 p.m., there's a code stroke. 4:30, she's intubated, and hematology has provided the diagnosis of TTS. She gets platelets, cryo, IVIG. Overnight, she goes to the OR with neurosurgery, or in the evening, excuse me. Overnight, she continues to have progression, and her pupils are fixed and dilated. She then turns to the OR several more times, just with repeat clotting of her drains. And in the afternoon, a bivalve drip is started, and still she continues to progress, and ultimately loses all brainstem reflexes overnight. Her brain death exams were then completed the following afternoon. So I just want to briefly address the very recent literature on this. So this is a review and meta-analysis by a group in Greece, and this is currently ahead of print in the journal Neurology. It ultimately looked at 11 case series, 11 registry-based studies, and 1 open label single arm clinical trial for a total of 341 patients with CVST among about 4,000 patients with thrombotic event following a vector-based vaccine. This is through August of 2021. The authors do point out that they looked at both CVST with a diagnosis of TTS and without, since the diagnosis has been evolving, and as in HIT, thromboses can precede the thrombocytopenia. And the mean age for CVST was 45. 75% of CVST cases were in women, and the mean time between vaccination and presentation with thrombus was about 10 days. 46% of patients had no risk factors for thromboses. And among all CVST cases, about 68% had hemorrhagic venous infarction. And I just want to point out a couple of things. So this is the main table from that paper. So post-vaccination CVST was reported in 29% of patients presenting with any thrombotic events after vector-based vaccine. And then when you really narrow that down to diagnosis of TTS, the proportion of CVST goes to 51%. And so TTS ends up being, on their review, associated with a 14-fold increase in the odds of CVST at presentation. But what I found quite interesting about this is that while TTS is being likened to autoimmune HIT, CVST in TTS cohorts is about 51%, while CVST, at least per some of these studies, but CVST in HIT cohorts ranges from about 1.6 to 2.5%. And likewise, mortality in patients with TTS-associated CVST, which was almost always due to the neurologic manifestations of TTS, was 38%, compared with 4 to 8% of CVST in the general population. And some of these numbers were up to 61%, and that was just dependent on the timeline at which point TTS was familiar to the medical community. And so with that, I'm going to stop sharing, and I will let Dr. Garcia, our hematology expert, talk a little bit about pathophysiology. Oops.
Okay, thank you for inviting me. And let me just confirm you guys can see my slides. Yep, good, thanks. So before I make a few comments about pathophysiology, I just want to echo something that Amy said, that when we talk about a tragic case like this or take care of a tragic situation like this, I think it's easy to lose sight of the big picture of, of risk and benefit and statistics. And these vaccines obviously have been given to millions of people uneventfully. And although this case is incredibly tragic and this reaction to the vaccine is incredibly scary, we have to keep that perspective in mind. So with those caveats, I will forge ahead. So I'm going to be referring to this as vaccine-induced immune thrombotic thrombocytopenia, but it goes by many names, and you've already heard Amy refer to it as TTS, and I don't know what we're going to finally land on that everyone in the medical community is going to agree about, but just realize there's different names for this thing. It does bear some similarities to heparin-induced thrombocytopenia, as was mentioned, so I'm going to just remind everybody what heparin-induced thrombocytopenia is. And this is the slide I show the medical students that shows an unactivated platelet in the top left, which has many contents, but one of them is PF4, platelet factor 4, a protein in alpha granules, which is released when a platelet is activated for whatever reason in response to a vessel injury, for example. Under normal circumstances, PF4 can attach to the glycosaminoglycans or long sugar chains on the surface of platelets. But if a patient is exposed to heparin, it tends to also interact with heparin and bind to heparin to form a neoepitope. Now, in most people, that's not a problem, but sometimes some patients will develop an antibody for reasons that are poorly understood to this heparin-associated PF4 complex. And that antibody can, when it complexes with the antigen, fix the FC receptor on platelets, which can cause them to get very activated, to aggregate, and to break off microparticles and cause widespread arterial and venous thrombosis. And many of you may be aware that the pattern of this usually is that about somewhere between 5 and 10 days after heparin exposure, like a patient who's undergone heart surgery in this example, there is a drop in the platelet count, and the thrombosis can follow shortly thereafter. The key to clinching the diagnosis of traditional HIT is something called the serotonin release assay, whereby the patient's plasma is added along with a small concentration of heparin shown in the middle of the x-axis here to some serotonin labeled platelets. And if the patient has activating antibodies present, the platelets in the test tube will release this serotonin, and it'll be detected because it's nuclear labeled, and you have your diagnosis. Now, again, the key to this disorder is the recognition of the heparin PF4 epitope and the fixing of the FC receptors on platelets and the release of microparticles. That's different from, for example, drug-induced immune-mediated thrombocytopenia that we may think of as being more typical, such as with a beta-lactam antibiotic or vancomycin, where you get platelets are coated in antibody, but they're sucked up by macrophages. They're not activated and causing thrombosis. Their counts decrease. And whereas drug-induced ITP tends to cause very low platelet counts, like in the single digits most often, HIT tends to cause a much less severe thrombocytopenia. But as Amy alluded to, there's some important differences between, although these patients with VITT or TTS do have anti-platelet factor 4 antibodies, there's some important differences with classic HIT. So the analogy that's the similarities that are being drawn now in the heme world are more with something called spontaneous HIT, which is the development of a HIT-like syndrome in the absence of heparin. And this is something that has been long recognized before coronavirus was ever even a thing. And it's spontaneous HIT is rare, but it's characterized by the development of thrombocytopenia and thrombosis with anti-platelet factor 4 antibodies that activate platelets. And again, it occurs in the absence of heparin. It tends to be seen after infections or after orthopedic surgery. And again, it's a very rare but well-described phenomenon. And now we've added this vaccine-induced immune thrombotic thrombocytopenia to what seems to be the same pathophysiologic category as spontaneous HIT. Now, Amy correctly stated that cerebral vein thrombosis is extremely rare in people with classic HIT, but where it's induced by heparin. But in spontaneous HIT, if one looks back through the case reports, there's a picture of cerebral vessel involvement, and particularly cerebral vein thrombosis, that is striking and I think interesting. These are some case reports assembled by my colleague Ted Workington, who loaned me many of these slides. Now, what's been learned about spontaneous HIT over the years is that it responds best to IVIG. And this is an example of an actual case that Ted took care of a patient who developed the disorder, and only after receiving IVIG did the patient have a dramatic improvement in the platelet count, and ultimately went on to recover with also in conjunction with non-heparin based anticoagulants. But the patient, you can see in the left side of this graph, developed the thrombocytopenia and the mesenteric vein thrombosis before being exposed to heparin. As Amy's already said, patients with these vector-based vaccines were noticed to have this thrombosis associated with thrombocytopenia type picture. And these investigators in the New England Journal described that nearly all of these patients had these very high anti-PF4 antibodies. And in fact, they have PF4 dependent platelet activation. So when you add PF4 to their serum, you get a strong activation of platelets. The platelet, so you can think of this, if we go back to the cartoon I was showing you earlier, you can think of this as being the same cartoon, except there's no purple strand of heparin. It's just for whatever reason, this vaccine is causing the immune system to produce antibodies that are very strongly binding to PF4 and then activating platelets and causing the thrombotic consequences. I think I'm going to skip through some of this because you've already heard about the demographics. There's this weird female to male ratio and a predilection for the cerebral veins that I don't think is well understood. There is a very high case fatality rate, as you've heard, and this lists some of the risk factors for death, which unfortunately, I think this patient had all of them. And then Amy asked me to make a few comments about treatment. We do think that particularly in a patient who's not yet started to hemorrhage, as unfortunately this patient had, one would want to use a non-heparin anticoagulant. No one knows which one would be best. Bivalirudin, argatroban, fondaparinux, one of the direct oral agents would all be reasonable. And high-dose IVIG is an attractive option. And I don't have time to show it, but there are many case reports now, more than a handful of case reports of vaccine-induced thrombosis or thrombocytopenia where there was an excellent response to IVIG. Unfortunately, this patient, I realized, did not have one. Plasma exchange is also something that can be considered in refractory cases, and there's a good rationale for plasma exchange. This is a description here of 17 patients, many of whom survived after getting plasma exchange. And again, the idea is just to remove these the offending antibodies. It is recommended that one uses plasma rather than albumin as the replacement fluid when doing the exchange. So again, I want to thank Ted Workington from McMaster, who's written elegantly about this subject and was kind enough to lend me some slides, but I'll stop there to make sure to give others time to comment.
Thank you so much, Dr. Garcia. So at this point, we will go to Dr. Kreutzfeldt to talk a little bit about the neuropalliative care aspects of this case.
Thanks. Yeah, so, you know, as from a neuropalliative care perspective, I think my job is to consider this overall illness experience. So for the clinicians as well as the patients and the family in this, and you've all already touched on this, of course, there's a lot of emotions involved in this. And I have 2 slides that I'm going to share. And let's see. Present view. Okay. So, are you seeing the whole, the second slide, the first slide? So we see.
We're actually seeing the presenter view, Claire.
Yeah, I think you just want the regular slideshow view, Claire.
This one?
Yeah.
Okay. So just you. So now you're seeing the moral dimensions of experience, and that's it. Okay. So you know, I thought a lot, as Amy also brought up. I thought a lot about the moral dimensions of this, because it is, you know, here's someone who did something that we as a medical community vehemently recommend, and then they had a tragic adverse event that shakes our moral ground. And what I mean by shaking our moral ground is that we build our construct, or our moral construct, as what we think is right, getting a vaccination, and what we think is wrong, which is not getting one. And that, of course, so now that moral construct is somehow messed with. I think it reminds us that nothing in medicine is black and white, and that any recommendation that we actually make can have an unwanted adverse effect. And so the places that I went as I was thinking about this experience were what we know around error disclosure, and then how do we actually respond? And Amy had asked me maybe to think a little bit about what language can one use as one talks to these families, or this family who is who knows what happened. And I don't think you mentioned at the beginning, but I think, you know, this woman actually did not want to get a vaccine in the first place, and so got it because she had to. And so there's clearly some emotions in that. So I want to talk a little bit about that and how we approach family members, and then maybe even get to a little bit of how we can deal with our own feelings of guilt. So error disclosure is, the literature is sort of more on the ethical side, is this question around do we have a responsibility? We certainly feel a sense of responsibility in this. And do we owe the family an expression of not only regret, but a formal sort of apology that accepts responsibility? And I'm just going to put that question sort of out there for people to ponder a little. And we'll, I think, talk more about the emotion part of the conversation. I also want you to think about how to deal with our own feelings of guilt in this, and I felt like the closest place to go for this is probably moral distress. You know, this has the markings of moral distress. So you something horrible happened in someone that you cared for, and that you feel sort of part of what happened. And we talk about in moral distress that it's important to figure out what you could have done differently, or what you might do differently next time, because that can help you move on. In contrast to a sort of a more nebulous feeling like I feel bad about what's happened, because that tends to fester, that feeling, and increases that feeling of burnout. And so I think that's why I wanted to just bring up the word moral distress, because I think that's a bit of a feeling that you guys caring for her also felt. And so the residents of all we still have to write one. Yes. Do you still have the right, now it's approaching difficult communication, it sort of looks weird on mine. The residents have heard me talk about how important it is to respond to emotions and to acknowledge emotions in all of our conversations, and I think we all know that there are emotions in this. And Tony Bach talks about 3 levels of sort of deepening a conversation as we approach a conversation like that. So the first one is, and always think about what role the family plays in this. So what role the family plays in this, first of all, the family has to know what's happening here. So even as we think about the error disclosure part, or you know, our role is to be transparent. So what's an effective headline? An effective headline has a max of, I think, 10 to 15 words. Is at a 5th grade level of health literacy, and has sort of a balanced combination of enough information and enough meaning. So in this case, what would be a good headline to actually tell the family? I'm afraid it was the vaccine that led to all of this. It's the elephant in the room and they know it, so it's important to bring it to the forefront. Or this is what we see as an extremely rare side effect of the COVID vaccination. And then after we deliver this headline, we always pause and allow the family to show or feel an emotion. And the emotion always comes before actually the cognitive response. And so now I'm imagining it a little bit, how they might have. So Amy asked me, you know, if they come and say, if they just show maybe anger about what you just said, it's important to respond to that emotion. And how can we respond to that emotion? The residents have heard us talk about responding to emotion by naming them, which also sounds a bit scary at first, but actually helps the patient or family feel heard. So naming an emotion in this case could be, I wonder if you're feeling angry, or even, I can see that you're angry about this. An empathetic statement might be a little less scary to say, which is, I wish it were different. And then the 3rd level is actually what deepens this conversation further and is supposed to help us all move on by giving meaning to a conversation. And I think that's where we need to think about. The husband might say, you know, this all happened because of your stupid, you know, recommendation here. And so there, my internal reaction would always be to defend myself and give more cognitive information about medicine and COVID deaths and how rare this is. But of course, we know that this rarely helps that kind of response. And so one would again respond to the emotion. I cannot even imagine how hard it is for you to have to fear that she is dying because of something she felt forced to do. And here, you know, being curious and transparent are the key in that conversation. And I think what we've learned with our workshops is that it's often hard to go to these places, but if we do, we often do get rewarded because the family feels heard and understood by us naming that. I think the one thing that is hard to learn because it's necessary is authenticity, because obviously we need to be authentic in this. And that's all I have for you. So I hope John has a few more minutes.
Thank you, Dr. Kreutzfeldt.
Can we jump in here, Amy?
Please do. Yes. Thanks, Dr. Lynch.
So thanks for having me on, Amy. So my name is John Lynch. I'm an infectious diseases doctor. My job has historically been around the areas of employee health, infection prevention, sepsis, antibiotic stewardship over my career as a practicing ID doc, and obviously seeing patients as a small part of my life until 2 years ago, when I really shifted over to pretty much full-time COVID-19 response when we had the first patient diagnosed here in January of 2020, and it's been basically my full-time job since then. So just in terms of disclosures, first, I'm incredibly sorry for this family and this individual and the impact, and obviously for the stress that the team, the neurology team, had to undergo as part of her care. The other disclosure, though, is that I've been one of the key players in requiring vaccinations of healthcare workers throughout UW Medicine. I feel very strongly about that. I feel very passionately about that for all the reasons that David and Amy and others spoke about, because my primary job is keeping health workers safe, and by keeping them safe, keeping our hospitals open so they can do the work that we are charged to do. And so when I think about that, I am not an ethicist. I'm the farthest thing. I hope I'm an ethical person, but I'm not an ethicist. When I think about vaccine ethics, just some things that come to mind is when we think about things like requiring vaccinations or strongly recommending vaccinations or using other mechanisms to get people vaccinated, right? Convincing them. We think about a bunch of different things: disease severity, which I'm going to talk a little bit about, and I'll promise, Amy, I'll be brief. Vaccine effectiveness, which I'll show you in data. Safety in the target population, which I'm not going to go into, but David and Amy both spoke to around the safety of all the vaccines that we're currently using. And then social, cultural, and political considerations. And I would say the biggest things here for that last one, which I don't have time to go into, but could honestly be a huge conversation, is that we are trying to slow down the pace of COVID-19 against a wave of misinformation and disinformation that has made this whole process incredibly complicated, and can turn those conversations that Claire just talked about, instead of someone who did the right thing and had a bad outcome, to someone who maybe in the person's perception or the family's perception maybe did the wrong thing and had a bad outcome because of this misinformation. So just to kind of move forward, Amy talked about this. We've had, over 500,000 deaths in the world. We've had 250 million infections due to COVID-19. These are the data just for the United States since January of 2020. We're approaching 800,000 deaths in the United States. And I just want to be clear, that slope is still pretty steep, and there's no sign that slope is decreasing noticeably. When we look here in Washington State, look at simply case counts, we're getting close to 800,000 infections in in Washington State alone. So just in thinking about the impact here, and these cases, each of them lead to something ranging from asymptomatic to mild respiratory symptoms to people who require acute care, critical care. We've had more people on ECLS or ECMO at Harborview at the same time. Right now, I think we have 4 people on ECMO than we've ever had in the history of the ECMO process here at Harborview ever. 1 or 2 at the most. And we had 4 people continuously pretty much for 2 years. And then mixed in there with people who even get discharged, the issues around long COVID and the disability associated with that. When you look at case counts in Washington State, this isn't going anywhere. We've had a whole bunch of different surges. We may be at a plateau. We may be coming down slightly, but it continues to be a major issue. And as we move forward, this has really impacted how we're able to deliver care in our state, in our country, and across the globe. Our hospitals have never been this full, and that is slowing down and decreasing access for all types of care, from primary through complex care. Elective surgeries were delayed over this last year, and that impacted the population and patient level has been massive as a result. And the only thing we can do is to try to slow down this pace in order to help provide and increase access to care that is desperately needed. And we know about all the other things, access to primary prevention tools like childhood vaccinations, to pap smears, to substance use disorder treatment. This is looking at hospitalization counts. You can see this last wave in Washington State, it far eclipsed even the larger surges we had in the winter of last year with the number of patients in our hospitals. Now, any given day over this last surge, we had something like 1,400 people in hospitals across Washington State with COVID-19, on top of an already completely full system across the state. and always toggling very close to this idea of contingency or crisis standards of care, where then we're going to be moving to triaging of care to different people depending on different situations. So the role of vaccination in this, I know we're getting short on time, but here in King County, we are tracking this. You can find these data across the United States. But if you look at a fully vaccinated population versus a not fully vaccinated population, or if you look at the individual level, in King County, people who are fully vaccinated are 6 times less likely to be get infected. They're 36 times less likely to be hospitalized, and they're 18 times less likely to die. These are data in the last 30 days. You can see some of the breakdowns of the number there. And if you put this graphically, this is looking at the case age standardized rate over time for folks who are being hospitalized. You can see that blue line are the folks who are not fully vaccinated. You can see that gray line at the bottom is the difference. Now, as the numbers come down in King County, that difference is decreasing, but you go back and look at that peak about the incredible delta between the fully vaccinated versus the not fully vaccinated population on the count in cases. And this continues through things like hospitalizations and deaths. The vaccines, as David mentioned, have proven to be incredibly safe and incredibly effective in the midst of an incredibly devastating epidemic that has had untold ramifications across our patient populations and the care that we deliver. And I'll just stop there to give you time to sum things up. So thank you.
Can I make a comment, or maybe I just want to ask a rhetorical question, which is, I mean, I don't know much about vaccine supply versus total population, but even if one assumes, and I think that, I mean, Amy, you probably have read this more carefully than I have, but the data seem to suggest maybe somewhere between 1 in 100,000, but probably closer to 1 in a million for this TTS reaction to the J&J vaccine. But even if one assumes it's only 1 in a million, why would, I mean, John, maybe you can explain to us, why should we continue to use it when there are other vaccines where this horrible complication, albeit ridiculously rare, has never been seen?
No, I think it's a good question, David. And when we make these recommendations in our healthcare worker population, we actually give everyone the choice which vaccine they want access to. So we provide all 3. And for folks who are passionate about a single vaccine, for people who said, I don't want to be vaccinated, we say, well, if you are, for instance, a person who fits in the epidemiological highest risk group for the J&J, we'll say, you should probably get one of the mRNA vaccines. But if you're a 60-year-old man who's like, I want one vaccine, I do not want anything more, then we may say the J&J is an option. But we do provide that in those recommendations when people do, get to that point where they're having that discussion. I think that's a valid point. And I'm glad that was a thumbs up, because I hope that was right. Yeah.
This is Christina Mara. That was a really great talk. I mean, it was all really fabulous. I just read in the New York Times today that there's a documentary on the beginning of the epidemic in New York. It's a documentary of healthcare providers. It's going to stream on Hulu. That people say, if you could actually, we used wartime jargon to describe what was happening with COVID, but in wartime, we show people what it looks like. We haven't shown people what it looks like, and this actually would, and it's apparently very powerful. So that's something to think about and maybe to recommend to our patients, to see what it was actually like to take care of these people, especially in the beginning when nobody knew what to do.
So I do just want to say thank you so much. I do wish each of you had an hour. I also just want to say thank you to Dr. Longstreth and Davis for helping me plan this, and Dr. Zant too for the clinic support, and obviously the UW teams that care for this patient, excuse me, and my co-residents. I know we're a little bit over time, but if we do have time to take questions, given that we have everybody here, that would be great.
Amy, it's Mike Williams. I have a couple thoughts about the ethical questions that came up, and when we talk about that, we sometimes feel like we're dancing around the question of, was something unethical done? And you can put that broadly into an organizational ethics perspective, which is, what do healthcare institutions owe to patients and to employees and faculty and so forth, and even a larger level, as John Lynch described, all of the ethical balancing that goes into determining the safety of vaccines and determining whether the risk-benefit ratio is appropriate, as well as all the other ethical activities that follow that, which is disclosing the risks, monitoring the potential complications of the vaccines, reporting those to the public, turning that into informed consent. Do you want this type of vaccine, which has this set of risks and balances versus the other type? And I think it's important to observe that this has been above board from the very beginning. If we were hiding complications, or if we were pretending that there wasn't a relationship between this person's individual dose and the complication, that's what would be treading on moral ground. So I think it's important for us not to imagine that we've crossed a line there. It is incredibly tragic. And Claire talked about, how do we deal with our own emotions? And one of the things that I would teach residents and fellows when I was a neuro ICU attending is that I think you have to step back and not necessarily ask, how am I going to respond to this event, but how am I going to deal with all of the emotional distress that we face in our jobs, whether that's in critical care or palliative care and so forth. And I think where people sometimes make the wrong turn is to turn that inward, as opposed to putting that energy outward. So I've always put that emotional energy into taking good care of patients and families. And I think that probably what a lot of us who are in critical care or who have careers in palliative care do. They take that energy and they turn that outward. So I do want to help the audience to understand that, at least as I view it, with my background in medical ethics, I don't see that we've gone in the wrong direction.
Can I just echo that? And I just want to say that I think but I also want to echo something John said, that what's so concerning is that all this misinformation that seems to have gotten unbelievably, prominent exposure due to social media technology and celebrity status of individuals who use their microphone in an unfortunate way sometimes, has, I think, made it seem to maybe some disinterested members of the public or independent members of the public that we're not being transparent, as a healthcare community, or that we're not sharing all the information, and it's just unfortunate.
Yeah, I think something in that vein that I was looking at was the language of how the CDC kind of defined the risk of TTS with vaccines, and how do you kind of articulate that risk if it is so rare, and yet if it happens, it is so severe. And I think that's also kind of where the ethical question gets in, is how you actually define and communicate that to people and to the public.
Right. It's hard enough to do that even if there weren't all this distracting misinformation going on, but boy, that becomes a real double whammy.
Yeah.
Claire, you're
Claire,
muted.
you're muted.
But I'm using my phone. Are we still muted?
You're good.
Oh, that's weird. I agree that I think that's where I think it's more of a moral dilemma that just the providers were facing. Like we all know that, you know, the vaccine mandates and everything that John tells us to do is the right thing, you know? And then we see a tragedy that just messed with us. And I think being still able to show this family compassion without judgment is often that challenge. And maybe also always a good reminder that these are people. You know, I think it's easy for us to sort of see those people who are the anti-vaxxers as someone else, and then they're right in front of us, and we're taking care of them. And that's what our profession also brings with it, of course.
Just as an aside to that point, Claire, you know, one of the hardest things that I've seen happen, and I'm sure you have as well, is when I walk through our ICUs and talk to the nurses who have been, and the therapists and other care providers who have been taking care of patients with COVID. You know, 4 of them on ECMO right now at Harborview, and many other requiring high levels of critical care, all of whom are not vaccinated. And that feel of doing that over and over and over and over again has been, I think it's been devastating. I don't think that's overstating it to the healthcare teams doing that work. It's just a very hard situation to see happen. I know we take care of patients all the time who, through, I don't want to use the word choices, but through things that happen in their life, impact their health. And then those health, what that happens in their health ends up in the hospital, right? All the time. But this particular decision around not getting vaccinated and getting sick and requiring that level of care seems to be very distressing to people.
So John, I would add to something Claire said earlier. I think that's the actual source of moral distress that caregivers feel. Moral distress is when you find yourself in a circumstance where you want to do the ethically right thing, but the system is not allowing you to do that. And the moral distress is, you know, we're doing the right thing. We're advising people about vaccines, and there's this other force that's coming against us, and we feel helpless about that. And we feel terrible when we have people come in who could have gotten a vaccine and who didn't and are terribly, terribly ill. That's an emotional distress on us. And I think the other thing that's very tempting to feel, and we all have to struggle with, how do we feel with this emotion, which is to look at them and say, well, you did it to yourself. And we have those thoughts. We don't always articulate those thoughts. And then we have to struggle with, okay, I just had this bad thought. What do I do with it? But I think what is more important is the actions that we take. You know, all of us in caring for families who are very, very ill have to suppress some thoughts that are easy to have and to be compassionate in how we take care of them. Where we often see that play out, however, is the stories we tell and the things we say back in the lounge where we hope we aren't being heard. But those are emotional coping skills. But I think the real source of emotional distress is that people are fighting us when we feel that we're doing the right thing. And that's what makes us feel helpless. That's what makes a lot of us feel helpless in this circumstance.
Yep, I agree entirely, Mike. You said it much better than I did. My deep concern is that the tools that we've been providing people to help with that aren't working anymore.
Amy and everyone, this is Chris Ransom. Thanks for this wonderful Grand Rounds. It's maybe the most topical and meaningful discussion in neurology Grand Rounds ever. So my question is, my understanding of vaccines are that we're introducing an immunogenic epitope to generate these protective antibodies. So are there any thoughts or ideas on why this condition is occurring with vector-based versus mRNA vaccines? And is it occurring with COVID infections?
I can make one quick comment about that. There's some thought that PF4 may be important in the response to a variety of infectious organisms, bacteria, viruses. There's some evidence that PF4 coats such organisms and that stimulates the humoral antibody response and also the generation of neutrophil extracellular traps and a whole bunch of downstream stuff. So this is theoretically, at least to my understanding, the pathophysiology of this is it's a good, like many things in autoimmune disorders or immune disorders, it's a good response gone bad. But why it would happen with the viral vector as opposed to just the mRNA, I don't know.
Thank you.
Well, if there's no other questions, thank you so much. That was a really great discussion, a very difficult case.
Yeah, thank you again, Dr. Garcia, Dr. Kritzkel, and Dr. Lynch. I really appreciate it.
Thanks for inviting me. Appreciate being part of it. Have a great afternoon, evening, everyone.
Thank you very much.
Thank you all.